When we investigate neurodegenerative diseases, we typically treat them as isolated events inside the skull. We look at cortical amyloid plaques in Alzheimer's, or Lewy bodies in the substantia nigra in Parkinson's, framing the breakdown as a strictly local, brain-bound problem. This creates a structural blind spot. We observe that systemic factors like gut dysbiosis and peripheral inflammation strongly correlate with dementia risk. But treating them vaguely as risk factors avoids the mechanical question: how exactly does a sick gut reach up and instruct the brainstem to degenerate? We are missing the physical wire. That missing anatomical cable, linking the inflamed periphery to the degenerating brain, is the vagus nerve. For decades, classical physiology categorized the vagus primarily as an autonomic motor nerve, the rest and digest signal. That view is obsolete. The vagus is a highly active, bidirectional neuroimmune conduit. It performs three distinct roles in chronic disease. It reads the immunometabolic state of the peripheral organs. It actively attempts to restrain peripheral inflammation. And when the system collapses, its physical axons act as a highway conducting pathology directly upward. To understand how neurodegeneration actually begins, we have to abandon the cephalocentric view. We have to map the specific neural wire that forces the brain to experience the sickness of the body. The most critical architectural fact about the vagus is its directionality. 80% of its tens of thousands of fibers are afferent. They are sensory wires, carrying data from the viscera up into the skull. This high-bandwidth instrument registers gut hormones, butyrate, and cytokines within milliseconds, firing continuous reports upward. This data arrives at the nucleus tractus solitarius, or NTS, the brain's first reader, which relays it directly to the locus coeruleus, the very earliest site of Alzheimer's pathology. The locus coeruleus is intrinsically fragile. Its neurons fire tonically and sustain massive, unmyelinated projection arbors that reach across the brain. This structure keeps its energy economy operating incredibly close to its bioenergetic ceiling, constantly hungry for NAD+ and ATP. When the body ages, or develops metabolic syndrome, or suffers chronic peripheral inflammation, it generates an abnormal, continuous signal. The afferent vagus dutifully reads this inflamed state and forces the NTS to relay it upward. This translates into chronic hyperactivity at the locus coeruleus. The demand of constantly processing this peripheral stressor drives the nucleus past its metabolic limits, exhausting its integrated stress response and depleting its baseline energy reserves. The locus coeruleus does not fail first by random chance or bad luck. It fails because it bears the immense bioenergetic cost of constantly reading a sick, inflamed body. The remaining 20% of vagal fibers function in the opposite direction. These are the efferents, the motor wires that project commands from the brainstem down to the body's interior. This descending pathway is a neuroimmune brake called the inflammatory reflex. The vagus signals the splenic nerve, stimulating T cells to release acetylcholine onto macrophages, binding to alpha-7 receptors to halt cytokine production. Crucially, the brain's microglia express this identical alpha-7 receptor. Central cholinergic tone acts as a dynamic, constant brake on microglial activation. It runs in parallel to other homeostatic signals, suppressing the nuclear transcription factors that would otherwise trigger a neuroinflammatory storm. As we age, global vagal tone steadily declines. This withdrawal of parasympathetic control is clinically quantifiable. We measure it as a continuous drop in heart rate variability over the human lifespan. This vagal withdrawal executes a devastating double hit. In the body, the failing reflex raises the baseline inflammatory set point, unleashing massive systemic cytokines. Simultaneously, inside the brain, the drop in central tone removes the acetylcholine brake from the microglia, a microglial population that is heavily primed by circulating peripheral cytokines, yet completely unrestrained by neural cholinergic tone, will inevitably transition into a disease state. Age-related neuroinflammation is permitted to occur because the vagal brake has failed. In Parkinson's disease and related synucleinopathies, the vagus assumes a physical role. It functions as a structural highway along which pathology itself travels. The prion-like propagation model demonstrates that misfolded alpha-synuclein can template and spread transsynaptically. It originates in the enteric nervous system of the gut enters the long, unmyelinated axons of the vagus and physically ascends the nerve directly into the dorsal motor nucleus in the brainstem. The most compelling proof that this route exists in humans comes from an inadvertent lesion experiment. Decades ago, severe peptic ulcer disease was routinely treated by physically severing the vagus nerve in a procedure called a vagotomy. This chart displays survival curves for Parkinson's incidence from massive Danish and Swedish registry data. Patients who received a full truncal vagotomy, severing the entire vagal highway, had a drastically reduced risk, whereas a selective vagotomy, leaving the main trunk intact, offered no protection. This mechanism defines the body-first phenotype of Parkinson's disease. In these patients, the pathology announces itself through prodromal autonomic symptoms, like severe constipation and sleep disorders, years before motor symptoms appear, tracking the exact upward trajectory of the nerve. By severing the vagus, surgeons physically isolated the brainstem from gut-originated pathology. The protection granted by that cut proves that this specific neurodegeneration travels via systemic anatomical routes. If we pull back from the individual mechanisms and map them onto the brainstem, a striking geographical convergence emerges between the NTS, the locus ceruleus, and the dorsal motor nucleus. These three structures form a highly concentrated, interlocked triangle located right at the dorsal medulla and pons. This is the anatomical interface. This resolves a major paradox. Both Alzheimer's and Parkinson's pathology implicate these exact tiny deep brain nuclei before they damage the cortex or the substantia nigra. They fail first because they sit exactly where the peripheral conduit meets the central nervous system. Recognizing this junction redirects our therapeutic objective. For decades, medicine has focused on clearing late-stage cortical amyloid plaques or managing nigral motor failure. We must instead focus on securing this vulnerable brainstem interface before the chronic peripheral load collapses it. The brainstem junction is the literal coordinate where an inflamed, metabolically stressed periphery is written into an irreversible central trajectory. This framework also explains the clinical failures of early vagus nerve stimulation trials for dementia. Those trials applied phasic cervical stimulation to patients who already carried a clinical diagnosis. By that point, decades after the pathology began, the brainstem junction had already structurally collapsed. A viable preventative approach requires stimulating the circuit before the failure. Transcutaneous auricular vagus nerve stimulation, or TAVNIS, accesses the nerve non-invasively through the external ear, making it suitable for long-term, low-risk application. Used alongside alpha-7 nicotinic receptor agonists, TAVNIS provides tonic, preventative support. It artificially restores the cholinergic brake on the microglia and reduces the afferent inflammatory load burning through the locus ceruleus. Under this model, we use HRV as a direct clinical readout of the neuroimmune brake's integrity, a measurement of how effectively the vagus is restraining central inflammation. A patient presenting with low HRV alongside elevated peripheral inflammatory markers is an individual whose locus ceruleus is actively under siege. They are the ideal candidate for early intervention. The proposition that neurodegeneration is a systemic disease can no longer be treated as a metaphor or a loose correlation between lifestyle and cognitive decline. It is a hard anatomical reality entirely wired together by the vagus nerve.